Our next session is on the management of end-stage neurodegenerative illnesses, and I'm so happy to present to you our two speakers. So our first speaker, and I believe they're going to present together, our first speaker is Dr. Jeff Hall. Dr. Jeffery Hall is a neurosurgeon and assistant professor of neurology and neurosurgery who specializes in the surgical treatment of epilepsy. He holds a graduate degree in neuroscience, neuropsychology from the University of Western Ontario. Dr. Hall obtained his medical degree at the University of Toronto, and he completed his neurosurgical residency at McGill, MNI, MNH. He completed a fellowship in the surgery of epilepsy and joined the MNH in 2004. His postdoctoral training was supported by the Department of Neurology and Neurosurgery at McGill and the Deitweller Traveling Fellowship from the RCPSC at Harvard. He has completed a fellowship in palliative care at McGill University in 2017. Oh, you have a fan back there. Dr. Hall aspires to deliver excellent quality patient-centered care in a collaborative, multidisciplinary context in order to maximize the quality of life for patients, and he is active in teaching and mentors several residents. He is a member of the Neurosurgery Examination Committee for the RCPSC. With him is presenting Justine Gauthier. Justine is a nurse, and she has a master's degree. She graduated from the Université de Montréal in 2009 with a Bachelor of Nursing Science. Then she got her master's degree in nursing with a specialization in nursing education in 2014. She has been working at the MNI, Montreal Neurological Institute, since 2008, starting in the neurosurgical unit as a staff nurse. She then moved on to the neuro-oncology ambulatory clinic as nurse pivot between 2013 and 17. She has been the nurse clinician working in the neuropalliative care and pain program since its inception in 2017. And in parallel to her hospital work, Justine is a course lecturer to nursing master's students at McGill since 2023. Fun. So join me, please, in welcoming them both to the podium.
Good. Well, thank you very much for that. Thank you also for the day. I really appreciate all the organization that went into this and for the invitation. It's nice to be back amongst the palliative care colleagues again. I feel like there's been a big break, so I really appreciate the chance to get back in touch with people and to share maybe a little bit what we've been up to. So I guess one of the disadvantages of going at this point in the day is that we're a little bit tired, maybe, but the advantage is that there's already been some talks touch on what we're going to present on, so some of it we can maybe elastic the way through and make up with other time. I think I changed the topic of the talk, right? I'm not sure I meant to do that, but
Did you?
So I think what's written there is about end-stage neurologic illness, and I think it's actually quite important to talk a little bit what happens earlier in the trajectory for these patients, because the end stage you're probably all familiar with, and it often looks like a common final pathway. But I think earlier on in those would be good. So I want to talk a little bit about the development of our program, and then some of these different patients we see, and incidence and prevalence of disease, et cetera. So I think for both of us, not much to declare except a little bit of support from different companies at times, but I don't see a way in which it's going to affect anything we should say to you today. If it does, please feed back to us. And this is unchanged from what was in the objectives prior. So I think by the end of the day, we hope that you'll have some more understanding of what we mean by neurosupportive care for neurodegenerative diseases, to look at the demographics of the specific groups, because we'll see that some groups that have quite a high incidence and prevalence, we don't actually see that much, i.e. dementia, and other things like ALS, MS, Parkinson's disease. There are fewer in the population, but we see more frequently in a hospital setting. I think it's also important as palliative care specialists to understand what's going on in terms of disease-modifying therapy for some of these illnesses, because there's rapid work going on this, and there is a change of the trajectory of some of these diseases, and so it'd be important to know about those, I think. And then we'll touch on some ethical issues at the end in terms of our timing. The CanMed competencies, I think it's at least these three So I think this has almost been, it sounds like we lifted each other's slides, but it's really, I think, because we hang out together often enough. But neurologic diseases are largely incurable, and many reduce life expectancy. So all of the neurodegenerative diseases we're going to talk today, with possible exception of Parkinson's disease, have a significant limitation or impact on the overall life expectancy. What's different about neurologic diseases is that the trajectory is vastly more varied than it is for some cancer patients, although that also is in flux with the new treatments and disease-modifying therapy. But traditionally, neuro patients have had a difficult to prognosticate group. The other thing is that as the disease progresses and the disease burden increases, that's specifically characterized by functions of the dysfunction of the brain, so cognitive impairment, behavioral issues, and communication problems that make these things a little bit more personal and a little bit more specific.
And so this is a quote that we often use in our talks because it does guide, it serves as a guiding principle for our practice in the hospital. And so we see neurosupportive care as focusing on the relief of suffering and planning for the decline in death as an expected and natural outcome, and not as a failure of medical treatment, which could be sometimes a little bit challenging when working in acute care, because it's different from the goals that were set up by pretty much everybody else in the clinical setting. So this is also a slide that we like.
So I think what you're hearing also maybe and picking up on is this so-called word neurosupportive care, as opposed to neuropalliative care or palliative care for neurologic patients, however you want to do it. I remember one of the first talks I gave in palliative care and talked about, after doing the fellowship, being quite proud and okay with this term palliative, and then a wise man pulled me aside and said, you know, sometimes there's still some stigma there, you need to be a bit careful. And indeed, this is something that I think we all have seen and found, and so that there are different ways in which we're evolving to brand ourselves a little bit, and so we've seemed to have settled on neurosupportive care, but we don't shy away from palliative care, end-of-life care when it's appropriate. It's just easier sometimes to get a foot in the door, especially if you want to get it in early by saying, oh, we're pain and symptom management people or supportive people, as opposed to palliative, which has an initial sometimes difficulty. So all neurosupportive care means is just the same application of the principles that we all know and understand, but applied to serious or severe neurologic illnesses. And when should we do that? Well, I think we should do it from the time of diagnosis. Maybe it doesn't seem too radical to this group, but it is radical to a tertiary or quaternary care hospital when those patients come in and are looked after. So these are the kind of patients that we see. When I went to go do my fellowship, it was more or less to try and fill in a gap of where I thought the transition from neuro-oncology care to palliative care was not being particularly well done by me, and that was a little bit my objective with that. Lo and behold, what's really happened is that stroke in our institute has become the #1 user of palliative care services. So as thrombolysis, including mechanical thrombectomy, has become the procedure du jour and is helpful, the greater number of patients are coming in with this, and some of those patients have more catastrophic strokes, and so they become our main client group. Brain cancer is still #2, and then all of these others, make up probably 10% of what we see. So the largest groups are by far and away neuro-oncology and stroke. So if ever you're looking for another talk on one of those topics, we'd be happy to come back and talk all day about that. But today we're going to talk about some neurodegenerative diseases. So, yeah, it's hard to make a segue into this particular slide, and it'll take a few seconds just to get the point across. So alexithymia is a fancy word meaning an inability to describe your own emotional status or your own emotional reaction to a situation that's going on. I think more or less surgeons are selected or encouraged to have alexithymia. So I think that it's hard to explain this concept to surgeons, but I got exposed to this by you all, and now I have it too, or I have some need to get out of that. It's also been interesting for me in the talks that I've given about neuropalliative care. At the end, questions are often about, So how do you deal with that, and how do you protect yourself on an ongoing basis when you're in that kind of difficult environment all the time? So that's what our colleagues are looking at for me. And I think it's also true that if we look at our traditional learning and textbooks and so on, like issues about self-care, et cetera, have usually been put by the wayside, but I think over the past 10 years, they're certainly more commonly talked about. And it's something that we try to encourage, because I think, and it was mentioned today, of course, of resilience and these kind of things, and that's really the only way out, I think, is to find some other way to resource yourself. So when I was, back in 2016, this was one of the main textbooks in palliative care. Just a few pages out of the book were about neurologic patients, mostly ALS. Same was true for the Oxford textbook in palliative medicine, just a few pages, mostly on ALS. And then along came Dr. Barasio, I had the opportunity to work with for a little while. He produced this book, which is all about ALS, and indeed that's where neurosupportive or neuropalliative care came out of in terms of the neurology environment. Those are the people who were looking after these patients for a long time, which of course had at one point no treatment whatsoever. And so it was the neurologist who took on that responsibility and developing palliative care directed with those patients. But then they went on to produce this textbook. Well, let's look at palliative principles applied to other diseases. This book is about, I think, 20 years old easily now. But within the last few years, there's new kids on the block that in the States in particular that are producing a book like this. So it's kind of interesting to be part of something that seems to be growing from different parts around the world. There's a newly established International Neuropalliative Care Society meeting, which I had the chance to go to back in September. And these folks were all there. It's kind of like nice. It's a small group of people. You can still get to meet them all, et cetera. But it does feel like there's something growing in that direction. So if we just, again, you've seen already this, but just to show you again now in terms of prevalence, so the overall number of people in the population who have a particular illness, so traumatic brain injury is there as number one, but that's sort of all comers. So if you get rid of the mild and moderate TBIs, it's a much smaller number. But apart from that, neurodegenerative disease, as we saw in the last talk, and I think Marianne showed also, that the numbers here are staggering. So this is a problem, and it's going to be a larger problem. Do we see it in the hospital? No. Do you see it in the CSLD and so on? Yes, I think that's where most of those people are, but we're going to see a lot more of it in the near future. Stroke and glioma, like I talked about, and then these are the neurodegenerative diseases that remain down here, so they're not very prevalent, but those are the ones that we happen to see in the hospital because they come in with difficult to manage symptoms at home. So I don't think we need to go over dementia so much. It's been talked a little bit about, but I think we're saying the same things. Dementia upon presentation is often subtle, small changes in cognitive abilities, which would be unusual for the individual. So it's a relative thing. And it's an umbrella term for all kinds of diseases which lead to a progressive deterioration of cognitive function, behavior, inability to perform ADLs, see, speak, move, etc. So again, it's not about memory per se, but it's about all cognitive function. The way neurologists talk about it is though it proceeds through stages from mild, just some cognitive impairment that's not really impacting your daily life too much, moderate, where there is some impact on your daily life, severe, where you're unable to ambulate or feed independently, and then terminal, bedbound, or unable to communicate and swallow. And if we're to see these in hospital, those are the ones that we see. There is one particular kind of dementia that we'll talk about, which we haven't talked about yet today, which we do see. And it's coming up. So as also it was mentioned previously, Alzheimer's is the most common, about 80% of dementia is in this kind of subtype. Multi-infarct dementia is next. Then there are some other pathologic differences between the other major categorizations of dementia, with frontotemporal dementia, Lewy body dementia, and the one that I told you about that we do see in the hospital, which is Jakob-Creutzfeldt disease. Oops. So we're going to talk about this later, but Jakob-Creutzfeldt disease or Creutzfeldt-Jakob disease is basically dementia compressed from a 10 or 20 year time span to weeks or maybe even days. So it's a very impressive dementia, which unfortunately we do get some exposure to from time to time. So just showing the problem with dementia, the incidence is related to age. It does have an impact on your overall survival. And those are the statistics in the US, and there's no reason to think they won't be different here in terms of what's going to happen with dementia in the next coming 20 years. So we're going to see a doubling. Is there any disease-modifying therapy? So I think it's important for a second to talk about what does that mean, disease-modifying therapy. It's an intervention, medication device, that produces an enduring change in clinical progression by interfering with underlying pathophysiologic mechanisms of the disease process. So all of that to say that even if we use this definition, it's kind of setting yourself up to talk about a device like a stimulator or neuromodulation device or a medication. So for example, we know that palliative care from that Tamel study, which people are familiar with, can add to someone's overall life, not just quality of life, but overall extent of life. So in that way, palliative care could be considered a disease-modifying therapy, but not according to a definition like this, which would restrict to something pharmacologic per se. There has been a monoclonal antibody. It was intended to slow the progression of AD approved in the US in 2021, but not in Canada. This is an interesting slide that's by an advocacy group in the States that just kind of tries to put it in perspective of where dementia is with respect to some of these other diseases. It's of greater prevalence and greater lethality than COVID-19. It's an ongoing pandemic. Its cost to America in terms of direct medical costs is significantly higher than cancer. So it's for all those reasons that were mentioned in the previous talk too about medical costs and cost to the people around and so on. There are medications, of course, that can be used for symptomatic pharmacology, as Louise showed in her talk. I think I can't do better than she did in terms of give a talk on the pharmacology, but there are a number of medications that can be used to try to help with some of the symptoms associated with dementia, but there are no disease-modifying therapies for dementia.
Sure. So like Dr. Hall mentioned earlier, CJD or Creutzfeldt-Jakob disease is a dementia that's essentially, it's a disease that unfolds very rapidly over a short period of time, and it's very rare, thankfully, but in the hospital or in the tertiary setting, this is something that we see because patients will be referred to us for this. And so I won't get too much into details, but it is a prion disease, and there is no disease-modifying therapy for this. Unfortunately, there's a stigma attached to it, so I don't know if anything comes up to mind to you when you hear this name, but a lot of people are still associating it with mad cow disease, or are wondering where this patient got this from. Is this infectious to them? And it's also extremely difficult for family members, not just by the devastating nature of it, but also because some forms of CJD are hereditary, and so some patients, families will choose to have the genetic testing done, and that will obviously bring an enormous amount of stress to them. There is a federal program, the surveillance program for CJD, and so when patients do have confirmed CJD, the family can have support from this entity that's based in, I want to say Manitoba, I believe, or actually is it Ottawa? Anyway, but they're very responsive, and they're especially used to helping family members through the grief afterwards, because some patients will have to undergo autopsy for confirmation of the dementia. And so this actually, adds more burden to the family members, because the person actually has to be sent away for the autopsy. It's not done in all regular morgues. And anyway, I'm going to spare you all the details, but it just adds to the amount of stress that the families have to go through. Personally, in the last maybe 5 years, I've seen a handful of patients with this disease, but I have not forgotten any of them. It's extremely traumatic for team members, for the families. Patients come in walking, talking, and then within a few days, they can't even close their eyes anymore. So anyway, in most cases, we found that palliative sedation was the only way to relieve their symptoms and the existential distress associated. Do you have anything else you want to add?
No, it's perfect. I think it's like that. It's kind of like a pressure cooker. So instead of having a dementia over 20 years, which is clearly, some people feel too long, this is clearly too fast. Yeah. And it's difficult to deal with in that way. So about dementia and neuropal or neurosupportive care, I think this was mentioned earlier in the day, and it just makes sense to us all. I think when do we start talking about things? Well, it's at the time of diagnosis, because most of these diseases will progress, and you will universally lose decision-making capacity at some point. So it's always better to have a conversation. Indeed, as Marianne was saying, that things can change over time too. So you have to let that let there be some avenue for rethinking. But if you really want to get people's idea about this, you have to do it maybe at a time that you consider uncomfortable while the patient's still quite well, knowing that there'll be a time when you'd like to have had their advice written down. Also, I think it's been well stated today throughout the different talks too that caregiver burnout for dementia is extremely high. And bereavement is complicated by this personal nature of the disease and sort of like one loss after another. Just when you think it's bad, it's not. 5 minutes and finish the talk? Okay, we'll go fast. So Parkinson's disease, it's got a quite high incidence. The reason why it has a higher incidence compared to the other neurodegenerative diseases is because no one dies of this per se. There is no disease-modifying treatment for that. It's associated with bradykinesia, resting tremor, rigidity, loss of reflexes, and can present intermittently at first, just in one limb, and then spread to the other. As it gets more advanced, you have to know about Parkinson's disease, although we call it a movement disorder, it's certainly not restricted to that. And with progression, people have difficulty also with speaking, walking, insomnia, cognitive problems, behavioral problems, depression, fatigue, urinary problems, constipation, memory disturbance, brain function. It's a bit like the others. It may progress on to dementia. As I mentioned, no available disease-modifying therapy for this group. So the other two groups we'll talk about quickly. There's tons of research being done and things that are actually coming out in the market, but for this one, no disease-modifying therapy. Symptomatic therapy for Parkinson's disease, it's obviously led by levodopa-carbidopa replacement, and in some people, deep brain stimulation when that's no longer effective. The pearl here, I think it's obvious to us, is to avoid antidopaminergic, especially the old-style medications in these patients if you need for sedation. Multiple sclerosis, so it's got a medium incidence compared to the other ones. It doesn't collect that much because you do die prematurely from multiple sclerosis. So symptoms at the beginning of MS are subtle and easily missed, but they reflect the area in the brain of where the plaques are, often starting with optic neuritis or particular sensory motor issues. Two main kinds, a relapsing remitting type, so that's the biggest one, and another one which is primarily progressive. In the end, most people will be wheelchair-bound, have pain, muscle spasms, limited mobility, bowel and bladder dysfunction, speech problems, cognitive function, sounding similar, and emotional dysregulation, swallowing function. Disease-modifying therapy for these guys, all kinds of it coming out, and more on the way. So these are all PO medications that are accepted as disease-modifying therapy for MS. There are all of these things. I don't think I need to go through the pharmacology or where these are potentially hitting inside the immune response that is thought to underlie, the autoimmune response thought to underlie this disease. But there are a number of things that can be given intramuscularly and subcutaneous. However, the new things involved now are these last two medications, which these are making up about 85% of all the infusion medications that patients with MS are getting. And then, of course, there is symptomatic pharmacology, which I think we all know about, and how exacerbations can be often curtailed or shortened by courses of steroids and appropriate pharmacologic medications otherwise. Last one to mention, so very small incidence, pretty small prevalence also. The reason why is that people get it fairly young, 55 average, and you die within 2 to 5 years after being diagnosed with that. Really quickly, I think everybody knows something about ALS. We all have a hook to hang on to now thanks to this ice bucket challenge, which was just 3 young guys who had ALS and challenged each other to do this, and then it went viral, and hence we all know about it. So that thing raised about $220 million for ALS. Also, if anyone, if you get anything from this talk that might be interesting, this is something to look up on your own. So No Ordinary Campaign is a documentary made by this fellow Brian Wallach, who is a young man who developed ALS got diagnosed with ALS a day after bringing his newborn baby home, second one from hospital. And he was a lawyer working in the Obama White House, so he knew how all the administration worked and how things, how to get money out of people or how to get it diverted and so on. He himself, through this documentary, you see how he was instrumental as an individual in terms of bringing ALS and going and showing the politicians this is what it looks like, and over time, through the documentary, showing that. And he was very successful at getting research funding diverted towards ALS. In the States, for Medicaid, you used to only get benefits after 6 months. He was able to get now a special exemption in the US. If you get diagnosed with ALS, the benefits start immediately, because 6 months is too long to wait when you have only a few years to live. And also the right to try new medications. So all of that, I think came a little bit from a single person. So it shows the power of advocacy that even a small group of people can have if they're well placed. ALS on presentation, 90% of it is sporadic. There's a few cases that are genetic in nature. Initial symptoms are classified in 2 groups, so bulbar onset brainstem or limb onset. And with the bulbar onset, it's swallowing, difficulties, emotional ability, and with the limb onset, it's tripping and dropping things, vesiculation. There is, at the end, the final common pathway that we see for this is shortness of breath, coughing, neuropathic pain, insomnia, constipation. Hypersalivation is big and real in these patients. They'll often tuck rags into the corner of their mouth to suck up the saliva, and they don't swallow well, so they tend to get aspiration pneumonias from that. So disease-modifying therapy for ALS patients. So the first ones were available for a long time, back in the 1995, and now there's enough data to say, oh, well, right, 3 months here, and then you can add another one administered by infusion in 2017. It might give you 6 months longer, so there are little gains there. But this newest medication, which is a PO or PT administered, we don't yet know exactly how long, because this is a little bit part of the medications that are being released, I think, more or less compassionately, but we have access to here also. So I don't know that there's super good data on how much more time, but it's helpful. And then the last medication there is specifically in the case of this SOD1. It's a specific genetic mutation that occurs in some of the ALS patients and works for them. And we can have access to it if we have proof that that's what they have. In terms of symptomatic pharmacology for ALS patients, there are some medications, quinidine and dextromethorphan, that seem to help with the pseudobulbar effect or the emotional lability that they have. The pain, neuropathic pain, is treated in the same way that we always do. So opioids for dyspnea, despite this being widely accepted in most palliative care places, neurologists still have some kind about giving these in patients with ALS, and that they're going to have a respiratory depression. But I think it's been very gratifying, the patients we've seen at a particularly appropriate stage in their illness, to introduce opioids. And it's not for pain, it's purely for dyspnea in this case, but it's very, very effective. And usual things for secretions. However, secretions may be so bad that it can overwhelm everything else you can do. You could try your tricyclic antidepressants, the scopolamine, that doesn't work. What's left to you, what's being done now, is Botox into the salivary glands at some points. And what had been tried previously, although it's kind of radical, is radiation of the salivary glands, but it may be effective doing too much. So I think we're getting close to out of time, but we can...
Yeah, I think so. So I'm actually going to skip this, but I think as a start maybe to the question period, we had some slides about ethical issues around feeding, hydration, and ventilation. So maybe that could inspire some questions from the audience as well. And so I think what we would like to get across is that a lot of patients with long neurological illnesses will have increasing symptom burden over time, and those symptoms can be very debilitating. And for example, with a patient with ALS who cannot swallow anymore but is still able to walk around, some of them will choose to have a gastrostomy or a jejunostomy for feeding. And so it is very important to have discussions early on in the course of the illness to understand what kind of life prolonging measures patients would like to have. And in the context of an illness that is longer sometimes, these measures may look heroic in the lens of palliative care, but for neurology patients, those are not always, the lens is a little bit different. So first of all, this is a question that I thought was really interesting. We, as nurses, doctors, physios, OTs, etc., we have training about ethical principles and what I think we have sort of a typical idea of what should be right and what's wrong, and so I think when we're faced with questions from patients and families about what to do next when things become more difficult, or if staff members are calling and saying, oh, there's this ethical dilemma going on, I think one of the questions that we can ask ourselves, and this has been particularly helpful for me, is to identify my personal bias. I try to always look out for my knee-jerk reaction, and then put it aside, so that I know that this is my own bias and that I shouldn't necessarily use it to guide a patient or their family or to be mindful of it anyway, when it comes to making tough decisions. Marianne talked about this a little bit too, and this is something that we like to talk about a lot. Our patients, most of them will have a problem with communicating at some point in their illness, whether it is just motor or also comprehension or production of speech. And generally speaking, what we have found to be efficient is to spend as much time as possible at the bedside. And I understand that for some other groups of professionals, it's not necessarily possible to have that luxury of time. But often we tend to defer to family members or to the person next to the bed who's well, to help us make decisions. This is not something unusual. We kind of all do it as a default, and so I think it's very important to be aware of that to avoid leaving the patient out of the discussion. I talked about this a little bit. Okay, and I think I'm going to end on this one. And again, Marianne's talk addressed this a bit, but our patients, generally speaking, don't fit traditional models of palliative care because palliative care was not developed for neuro patients. It was mostly developed for cancer patients. So a lot of time when patients do need services from palliative care, they don't necessarily tick all the boxes needed for referrals. So that's something that I see a little bit as my mission, is when we go out and do talks like this, I want to make sure that people in the community understand. And I feel like we've made a lot of progress in the last decade in terms of what's acceptable and what's not acceptable in terms of referrals for palliative care. I can see that there's a lot of receptivity. I'm sorry, I'm losing my English at this point. But I have seen that we've made some great partnerships with people in the community who are now seeing the patient kind of outside of those tick boxes. So I think there's still some work to do, but there's definitely more and more awareness. So I'm grateful for that. Do we have any questions?
Do we have any time for questions?
Do we have? Oh, yes. You did very well. We have time for questions. Does anyone have any questions in the room or on the chat? Vivian, are you asking a question?
We happen to have a patient with CJD right now, and it's hereditary, and the family's really having a very hard time with this. And her father and her sister died from the disease. Oh, wow. So I didn't catch, you said there's a follow-up program?
Yes. So actually when that protein comes back positive in the CSF, generally that the surveillance program will call the resident or whoever sends the sample to the lab. It's a national lab. And then from there, there's a person who gets assigned to the case. If you want, I can give
Okay.
you the information after, but
Perfect.
it should be automatic.
Okay.
Yeah.
Thanks.
And then they follow the patients after, well, the family members after.
That would
for
be
bereavement.
great.
Yeah.
Yeah, okay, thank you.
Perhaps you can share that resource with us.
Yeah.
And then we can also put it in the chat, and everyone can benefit from that information.
Absolutely.
Does that sound
Yes.
good?
All right, please.
Very good. Are there any other questions? Oh, here comes Jean.
Nice dog, Stephen. The question I've had is that definitely I feel that at least for in-hospital palliative care, neuropalliative care has transformed who is being hospitalized now. Apart from being being asked much more in palliative care units to accept individuals with catastrophic strokes and other very, very rapidly deteriorating neurological illnesses, a lot of our cancer patients are now thankfully finding very, very good palliative care in hospice in the community. And therefore, it's opening the doors, some people would say it's a floodgate, to the discussion around dementia and neurodegenerative diseases and strokes for palliative care. And in fact, that is, for the good of society, is really the direction which I see a lot of in-hospital palliative care going. I'm not sure if other people notice this in the room as well. But certainly, I'm wondering whether you've noticed that or whether you've sort of been participating in people saying, you know, we didn't used to accept these patients into palliative care, now we are.
So I think absolutely we're seeing that, and I think that we see it in our institute, and now being invited into the various neurology clinics of different disease specific clinics for ALS and for oncology, and also we're getting invited into the ICU now for consultation, which is something that I don't think happened 5 years ago, or not so often, but it does happen on occasion now.
I think if I can chime in, what's interesting with the ICU consults, because sometimes it seems a bit difficult to wrap our head around that, right? But we've noticed that some patients will, for example, have an extubation after a catastrophic stroke, will be transferred to the unit, and the reflex has become that if this patient is going to be transferred to the unit, either the ICU fellow or the doctor or the nurses, someone will flag right away and say, you need to refer this patient to palliative care. And I think that has been quite helpful, because traditionally, no, it doesn't really fit the palliative care model. This is really end-of-life care and should be part of the care continuum, right? But what we've noticed is to assure this continuity of care, it's been really quite neat for patients and families to meet us when they're in the critical unit, and then moving on to transitioning to the floor and having those familiar faces around. And also because the medications that are used in ICU are not necessarily translatable to unit use, where everything needs to be subcutaneous. So I think that's been the major breakthrough there, and why they've been involving us.
Yeah, and for stroke, I think we do see more referrals out of our center from strokes that might. Usually it's multiple stroke, right? I think it's generally on your second or third stroke that there's an accumulation of deficit and an unlikelihood of recovery, and then having all the complications associated with being bedbound, for example, or something like this. So I think you're right in that the landscape is shifting a little bit in terms of who would get into palliative care units like that.
I have a quick question. I think one of the frustrations for me is how black and white it is, or the impossibility for some to imagine that acute care can coexist with palliative care. And I'm speaking particularly for dementia. I think Marianne touched on this. And I love that you're getting invited into the ICUs and into other contexts of palliative care. And I guess my question is, how do we reach the community? The CHLSDs, the long-term care facilities where the majority of these patients are, where the knowledge isn't there, and it's frustrating as a healthcare professional who specializes in palliative care, but as someone who has a mom with dementia. And how do we spread that message that palliative care can start early, and when someone with dementia ends up in the ER, it's not an either or, well, what do you want us to do? when there's something acute that can be
Yeah.
treated that can lead to quality of life
Yeah.
and symptom management and send her back out. So I guess it's maybe more of a comment, but I'm curious if you have anything to say. So where do we go from here?
Yeah.
This is great. We're already converted. How do we take that message outward and elsewhere
Yeah.
so that early palliative care for patients with dementia and other neurodegenerative diseases get that attention and those assessments early on?
Right. So thank you for your questions, because I think that it's something that we've also reflected on and thought, because we're looking at the numbers and saying, well, where are all these patients with dementia? Yes, we're seeing the rapidly progressive dementias, but we're not seeing the slow burning trajectory of dementias that may go on. And that was a little bit my point at the beginning of saying, the time to think about palliative care and the time to have a difficult conversation is at the time of diagnosis. So that, because presumably the people that are getting into CHSLD, they're at the point where they probably cannot explain what their limits or wishes would have been. That needs to have happened before they get into the CHSLD. By the time they're there, then you're dealing with surrogate decision makers and the families and so on. So I suspect we need to do this through family doctors or whoever is, or through neurologists, whoever's getting an official diagnosis of a dementia. If it's made, it should, in an ideal world, it would somehow trigger either the neurologist doing that or the family doctor doing that or somebody doing it to have an advanced medical directives and serious illness conversation and levels of care, so that we understand and know what to do in the setting where most of these people are going to pass, which is in the CHSLDs, as far as I can tell.
And if I can add something to that, I think during the pandemic, the acute phase of the pandemic, there was a strong will into having field levels of care in acute care, which was quite a bit of a change in certain units where the culture wasn't totally there. But it's also happened that when patients were transferred out to CHSLDs, it was actually mandatory for them to have a level of care. Now, we can always say that by default, patients level A, the team doesn't want to talk about it, whatever, they just sign it and send it off. But I think policies like this, I'm hoping that I'm not sure it's still enforced. I don't see it as much in practice, but I think policies like this do have an impact where at transition points, discussing level of care with patients is, I think, crucial, and it's a good way to see where they're at in their reflection, whether it's at the start of their illness, or I find transition points to be really good for things like this. But anyway, I think also in CHSLDs, there's a lot of palliative care that's being delivered, and I would actually argue that some of the physicians that work in the CHSLDs would know a lot about palliative care. So I'm hopeful that it's just that it's not the same amount of resources maybe that are allocated for that in comparison to a palliative care setting.
Yeah, I think that's right. But in the end, I think we need to keep following it back to find out where's the point at which we can intervene with the serious illness conversation and level of care and advanced medical directives. And I'm not sure it's at the level of intake from the CHSLD. It's probably earlier than that. So we have more work to do.
I might pipe in. Palliative care is, it's Golda right here.
Looking for someone standing.
Palliative care, palliative approach, I mean, it's a team approach, right? So it's not just doctors, it's nurses, it's the physiotherapists, it's everybody. So whether it's in long-term care, or in primary, family physician, clinics, et cetera. Ideally, everybody understands the palliative care approach, and when there is a diagnosis of a serious illness, they should start being able to have the conversations with the patient, with the family, and hopefully have some knowledge on symptom management. And so this is why a conference like today, we try to make it multidisciplinary, and we try to make it open so that it's reachable for people in family medicine, but also working in long-term care facilities, et cetera, because yes, this is the good news, that there's always stuff that we can do for our patients, even when they have a serious illness, and even when we know that eventually it will lead to their death. So anyway, that's what I wanted to say.
Thank you. The multidisciplinary aspect is we're completely converted to this, and generally we do things as a dyad because we have different perspectives, and putting it together seems to be what helps. If we could add to that social worker, PT, OT, spiritual care, I would do that, but it's coming maybe one day soon. Good. Thank you.